Hello everyone, I'm Dr. Sailie Shirodkar from Narayan Nethralaya, Bangalore, India, and my talk for today is about the pain management protocol in post-photorefractive keratectomy or PRK and cross-linking patients. At the outset, I'd like to declare that my co-authors and I have no financial interests. Surface ablation procedures were among the first refractive surgery procedures to be approved by the FDA. So why are we still faced with the problem of patient acceptance? Although a small percentage of patients do face problems related to haze and regression, most patients achieve satisfactory visual outcomes following PRK. So the main thing is the post-operative pain related to the PRK, which has dampened the enthusiasm amongst both patients and surgeons. A quick literature search reveals that a great degree of research has been dedicated to developing ways to control post-PRK pain, right from oral analgesics and topical analgesics, gradually moving up to bandage contact lenses. However, the outcomes have not been satisfactory. So our previous research showed some promising results. Instead of relying on topical analgesic eye drops or plain bandage contact lenses, we decided to use a combined approach by injecting bandage contact lens blister packs with 0.4% ketorolac tromethamine for sustained and prolonged delivery. On assessment of the patient's pain on the Wong-Baker score, it was revealed that the pain scores had dropped on a scale of 0 to 10, with 10 being the maximum pain. Patients were reporting a score of 6. The results were heartening, but they also made us wonder if we could bring the pain down even further. So just as we were considering new avenues to explore, we came across this impressive piece of news that research into the TRP channels, mediators of heat, cold, and pain, had garnered the Nobel Prize. We decided to delve a little further into the history of coldless thermotherapy. So we were surprised to discover that the use of coldless thermotherapy has been around for millennia, with the earliest reference being in the Edwin Smith Papyrus, which is the most ancient known medical text. Ice packs were also used in Napoleon's army prior to amputations for an anesthetic effect. More recently, in medicine, William Osler's body cooling regimen was known to bring down mortality rates in typhoid fever. But with its use for cruel experimentation and concentration camps during the Second World War, the use of coldless thermotherapy faded into disrepute. So we decided to reconsider this line of management, which brings us to the research questions that we attempted to answer. Can using coldless thermotherapy in the form of refrigerated bandage contact lenses reduce post-PRK pain? Could the use of coldless thermotherapy have an impact at the molecular level? What is the duration for which the BCL will continue to release the drug in ketorolac-soaked PCLs? And does injection of ketorolac in bandage contact lens blister packs affect the sterility of the BCL? So research into the molecular mechanism of pain has revealed a considerable role of the TRP channels, the TRP channels, the transient receptor potential ion channels that are activated by cooling compounds. We decided to conduct a study to test our hypothesis. 202 normal eyes undergoing PRK for refractive correction and 249 keratoconus eyes undergoing laser-based cross-linking were recruited for the study. So can using coldless thermotherapy reduce post-PRK pain? This was designed to be a prospective interventional study. The recruited patients underwent a thorough clinical examination along with imaging, including corneal tomography, biomechanics, and epithelial mapping prior to undergoing the surgery. Advanced keratoconus cases or those with chronic ocular surface disease or inflammation were excluded from the study. 4 types of BCLs were used following the treatment: conventional with ketorolac, cold, and cold with ketorolac. So the BCLs were prepared under thorough aseptic precautions by cleaning the surface of the blister pack with an alcohol swab. Following this, 0.2 ml of 0.4% ketorolac solution was injected through the surface of the blister pack and allowed to soak for a period of 30 minutes. These were, of course, then refrigerated before placement on the patient's eye. So Wong-Baker scores were assessed on the first postoperative day. The conventional group showed the highest score with a mean of 7.28 in keratoconus and 7.43 in PRK respectively. These scores dropped progressively from the conventional to the conventional plus ketorolac, then the cold, and the lowest recorded scores were found in the cold plus ketorolac group. We decided to understand the impact at the molecular level based on the treatment used. So the BCLs from the first postoperative day were sent in phosphate buffered saline solution for analysis at the laboratory. RNA was extracted from the BCLs and then converted to cDNA, which was subjected to qPCR for analysis of gene expression. The cold group showed lower expression of TRPV1 and TRPM8 as compared to the conventional group. We also studied the expression of inflammatory markers such as the COX2, the cyclooxygenase 2, the interleukin 6, and a calcitonin gene-related peptide, which were found to be low compared to the conventional group. We then decided to determine the duration for which the BCL acts as a depot and continues to release the drug in therapeutic concentrations. So high-performance liquid chromatography was performed to analyze the drug concentration over various time points and assess the duration of release of the drug. We found that the concentration of the drug in the solution gradually increased until 1 hour and then remained unchanged. Does injection of ketorolac in bandage contact lens blister packs affect the sterility of the BCL? So swabs were taken from the surface of the blister packs, those sterilized before injection of ketorolac and those which were routinely used. They were cultured on blood agar, chocolate agar, and brain heart infusion broth. No microbial growth was noted on the clean surfaces. So let us understand the possible mechanisms underlying the achievement of analgesia using cryotherapy. The gate control theory of pain states that neural networks distributed along the dorsal horn of the spinal cord are responsible for relieving the pain in a specific body location when an intense tactile stimulation is applied at the same place. So we propose this to be one of the modes of action of using cryotherapy as a form of post-PRK treatment. Another mechanism is the reduction in nerve conduction velocity, which is found to be reduced as much as 30%, and reduction in the sensitivity to the pain receptors. So local application of cold has been known to reduce the sensitivity of pain receptors, much in the same way as it reduces the sensitivity of touch and pressure receptors. So the channels that we studied include the TRPV1, the transmembrane protein, which is activated by physical and chemical stimuli and responsible for pain transduction, TRPA1, responsible for transduction of pain and inflammation, and TRPM8, responsible for detection of cold and one of the principal mediators of menthol-induced analgesia of acute and inflammatory pain. The inflammatory markers that we studied include the cyclooxygenase 2, an enzyme responsible for inflammation and pain, and a direct target for NSAIDs. The interleukin 6, which is a pro-inflammatory cytokine responsible for development of pathological pain, and CGRP, the calcitonin gene-related peptide responsible for pain transmission and inflammation. So the mechanisms underlying the achievement of analgesia using a combination of cryotherapy and NSAID. In the cryotherapy is responsible for stimulation of the A-beta afferent nerve fibers as per the gate control theory, reduction of nerve conduction velocity, and reduced sensitivity to pain receptors. Also, because of reduced metabolic rate and reduced cellular activity, it also causes reduction in the inflammatory factors, whereas the ketorolac tromethamine is a direct causes direct reduction of the prostaglandin biosynthesis, which reduces the inflammatory factors. So what did we already know? We already knew that almost all patients complain of significant postoperative pain after PRK, and oral medication, conventional bandage contact lenses, even short-acting topical analgesics have yielded poor results. Our study has added a novel and convenient and effective technique to control post-PRK pain with no added risk of contamination, and has helped in identification of molecular targets for treating post-PRK pain. Of course, pain being subjective may be over or underreported based on environmental factors and personality types, and long-term follow-up is required to assess impact on the visual and topographical outcomes. Thank you.